Hello everyone. Today we are going to see lot of rare cases of pancreatitis. So let's start. There are two types of pancreatitis depending on the duration. One is acute and another is chronic. In acute type, the gland can reverse to normal, and in chronic type, the changes are irreversible. There will be irreversible functional changes. This definition is according to Harrison. Kindly go through it once. And there are many type of pancreatitis depending on the morphology and cause. These are chronic calcifying pancreatitis, chronic obstructive pancreatitis, autoimmune pancreatitis, group pancreatitis, metabolic forms, and hereditary forms. First case, 40-year-old male patient with chest pain. The first image is axial contrast and CT. It shows atrophic pancreatic parenchyma with multiple tiny foci of scattered calcifications. In the second image, there is a well-defined cystic structure in the mediastinum posterior to the cardia, suggestive of pseudocyst formation. Next is autoimmune pancreatitis. Autoimmune pancreatitis is a non-calcifying chronic pancreatitis associated with an autoimmune inflammatory process. Associations are biliary diseases such as sclerosing cholangitis and primary biliary cirrhosis, inflammatory bowel disease, Sjogren's syndrome, silenitis, renal involvement, and retroperitoneal fibrosis. Imaging findings are usually diffuse sources like enlargement of pancreas, which can be focal. There will be loss of lobulations. Enhancement is variable, often less enhancement than expected in arterial phase. Strictures of common bile duct are common. Low attenuation halo surrounding pancreas can be seen. 52-year-old male presents with pain abdomen and features of obstructive jaundice. In the first image, we can see edematous and enlarged pancreas. The surrounding fat is echogenic, suggestive of inflammation. In the second image, there are ill-defined hypoechoic lesions in the renal parenchyma. In the third image, there is dilatation of CBD with intrahepatic biliary radical dilatation. It is the same patient. First image is axial plane CT showing sausage-shaped pancreas with hypodense halo. Second image is contrast enhanced CT coronal section showing multisegmental strictures of the CBD with intrahepatic and extrahepatic biliary radical dilatation. Next case, 45-year-old male presented with multiple episodes of abdominal pain. Radiographs of abdomen show multiple foci of coarse calcifications in the upper abdomen. Ultrasound images of same patient showing dilated pancreatic duct with multiple hyperechoic foci with posterior acoustic shadowing. On color Doppler, these show twinkle artifacts suggestive of intraductal calcifications. Curved planar reconstruction of non-contrast CT images showing multiple varying sized calcifications in the pancreatic parenchyma and the main pancreatic duct with resultant proximal dilatation of the pancreatic duct. The first image is axial T2 weighted image at the level of pancreas. It is showing grossly dilated duct with hypointense signal void regions within, representing intraductal calcification. There are multiple areas of narrowing in the pancreatic duct. The second image is axial T1 post-contrast image in the arterial phase. It is showing enhancement of the thin dot pancreatic parenchyma. The duct is grossly dilated. These features are suggestive of chronic calcifying pancreatitis. The grossly dilated pancreatic duct with multiple areas of construction resembles chain of lake, so it is called chain of lake appearance. 42-year-old female, a known case of chronic pancreatitis, presented with sudden onset of epigastric pain. Axial CT showing duodenum encircled by a dilated pancreatic duct. There is absence of pancreatic parenchyma around this duct, likely sequelae of chronic pancreatitis. In the second image, we can see duodenum encircled by a dilated pancreatic duct. Also note diffusely enlarged pancreas with peripancreatic fluid, suggestive of acute on chronic pancreatitis. It's a case of annular pancreas with pancreatitis. Color labeled image of the same patient showing pancreas, pancreatic duct, and duodenum in a case of annular pancreas. 9-year-old boy presented with multiple episodes of severe abdominal pain. The main pancreatic duct is dilated and tortuous. It is seen draining into the minor duodenal papilla. The duct of Wirsung is seen draining into the major duodenal papilla. These two ducts are not communicating. In the axial T2 weighted images, we can see enlarged pancreas, and there is enlarged pancreatic duct which is tortuous, and there is mild fluid in the peripancreatic region. This is a case of pancreatitis with pancreatic divisum. 28-year-old male presented with epigastric pain since 1 week. Non-enhanced axial CT images showing fat stranding adjacent to the pancreatic head. In the second image, we can see fluid in the pancreaticoduodenal groove. This is a case of groove pancreatitis. 52-year-old male presented with left hypochondriac pain since 1 day. There is elevated serum amylase and lipase. Non-enhanced axial CT images showing fat stranding adjacent to the pancreatic tail. Next image is portal phase CT. It is showing similar finding. There is mild fluid and fat stranding adjacent to the pancreatic tail. This is a case of focal pancreatitis. 25-year-old male, a known case of cystic fibrosis, presented with jaundice. There is elevated alkaline phosphatase. In the first image, we can see there is fatty replacement of the pancreas. We can also see multiple dilated venous channels at the porta, such of portal cavernoma formation. In the second and third images, we can see dilated intrahepatic biliary radicals. So these features are suggestive of pancreatitis with portal cavernoma formation and portal biliopathy in a case of cystic fibrosis. 25-year-old female with pain abdomen. Axial CT show gas in the pancreatic parenchyma with adjacent necrotic debris. Color labeled image show air and thin dot pancreatic parenchyma. This is a case of emphysematous pancreatitis. 35-year male, a case of chronic pancreatitis, presents with weight loss, reduced appetite, and abdominal pain. Axial CT showing enlarged pancreas with peripancreatic fat stranding, few tiny foci of calcifications within. Axial CT in arterial phase show hypoenhancing mass in the region of pancreatic body. This is a case of chronic pancreatitis with adenocarcinoma. Thank you.